Dr. Laura Borgelt.
Thank you, Art. I really appreciate that. Just in terms of conflicts of interest, I don't have any financial conflicts of interest. I have served on 3 of the task forces for the rulemaking process, which has been actually very interesting. And I want to just state up front that I have, in this talk, I'm not talking about any maternal concerns. I'm really focusing on the fetus, child, adolescent as they grow from the womb, so to speak. And I also just want us to all accept that marijuana is a very lipophilic molecule that easily passes into the placenta and the breast milk. So with that said, I'm not going to give you my normal pharmacology spiel. I'm going to go right into the information here. So my objectives here are really just to describe the population at risk, the impact of marijuana on that population, and a little bit about the long-term effects that we see, and then hopefully at the end provide you a couple recommendations about what we should do to help this population. I want to just take a look at what cannabis use is like in pregnancy. Now, self-reports range in most studies from 4 to 5%, with estimates ranging up to 27%. Now, that's self-reporting. That's asking, do you use marijuana? Of course I don't. When we look at actual hard data when we look at toxicology, either through urine at that 3-week mark or through hair at the 3-month mark, we can see that the actual use of cannabis in pregnancy goes up quite a bit. And in a combined format in the past 3 months looks to be about 34%. In terms of studies that have been done with cannabis continuation in pregnancy, of course, we would assume that if women were pregnant, if found out they were pregnant, they might stop. But what we actually find in this UK study, we looked at lifetime use the year before pregnancy, the month before pregnancy, and then during pregnancy, what happened is that we saw that while women did reduce the use that they had from about 60 to 70% down to about 50%, on average, about 60% of cannabis users continued to use about 10 joints per week throughout pregnancy. Now, if anyone's been pregnant, you could maybe relate to the nausea that might occur with pregnancy. And that's one of the reasons why they might be continuing it. And so what we see in this study, again, a study out of Canada, 79 women who were pregnant, 65% of them reporting cannabis use during the pregnancy, and then of those experiencing nausea and vomiting, about 70% of them also using marijuana to relieve that symptom. And I think this is what I see in my clinical practice and my family medicine practice, a lot of women using cannabis for this purpose. And whether right or wrong, I'll tell you some of the risks for that, but the reality is it's happening. And so we just need to be aware of that in this vulnerable population. And with that, I want to just reiterate a little bit about what Amanda said so nicely this morning in terms of the endocannabinoid system. And what I really want to focus your attention to is that homeostasis model of the body always trying to regulate stability. And with that, we have these endogenous cannabinoids called anandamide and 2-AG that lie between the receptors to maintain that stability. We have it when we have temperature regulation, and we have it when we, have a fight or flight response. Those are all homeostatic mechanisms coming into play. But what we see here in the synapse, and I have to do this, I'm a pharmacology person, so you have to endure this slide, is what's happening at the receptor level between anandamide and 2-AG. And what we're seeing here is, again, that balance. When necessary, it attaches to the CB1 or the CB2 receptor, which are all over the entire body. And we think, at least in some research, that it's an on-demand phenomenon. So when the body needs it, it reacts, and when it doesn't need it, it detaches. And so that's kind of the simplified version of what happens. Now, if we take this same model in the fetus, we see that this is actually developed by 14 weeks, which is just after the first trimester. So it's been developing and is actually fully developed at this time. Now, in normal situations of homeostasis, that's all fine and dandy, but a lot of times we're using marijuana in unstable conditions or unstable conditions where the homeostasis may not be completely regulated or correct. However, I think we could all argue that in an itty-bitty baby growing in a belly, most of the time, that system should be pretty healthy and pretty well regulated. When we potentially bring marijuana, which in some ways can be seen like a hammer to the CB1 receptor, there are effects that can happen. And we know, and many of you have probably seen this picture, the variety of marijuana effects that can occur on a brain, and Dr. Riggs and Thurstone especially commented on the impact of marijuana on the brain. And now I'm going to argue that this is truly the most developing brain in terms of a fetus. It really is, from a very young age, extremely young age, developing to reach its full potential. And some other things happen during pregnancy that we may be concerned about. One of them is that there may be a supraphysiological stimulation of the endogenous cannabinoid system when that fetus is present. So we may see some disrupted endocannabinoid signaling. There may not be appropriate development with the synapses of the CNS. And then we also may have a disruption of the full neurotransmitter system. So things like dopamine, which is a neurotransmitter in our body, which is part of our reward system, is not fully developed, and it can be disrupted in that process. And so we see things that, especially in pregnancy, put the fetus at risk for being just a little bit out of whack. So my key point in this is that there are several potential mechanisms that exist through which this prenatal exposure could exert its impact. I'm not saying it always does, and I'm not saying it always will, but I think that there are these mechanisms, and we see it in preclinical studies, where there is definitely potential for this to happen. So we looked then at how should it be studied, and this is something that we've been exposed to already today, and I might just ask you to think about what would you consider to be the lowest level of evidence to the highest level of evidence, and maybe that's your opinion, right, or a blog, right? But what I'm going to suggest is most of us would say a randomized controlled trial or meta-analysis would be ideal. We have none of that in this situation. What we have are cohort studies and some case control studies. And so this cohort study is really the best level of evidence that we have. And I want to make you aware of 3 prospective longitudinal studies that you need to be familiar with if this is an issue that's concerning to you. The first is the OP study, which was started in 1978 in Canada. They really looked at marijuana and cigarettes. So they're not just focusing on marijuana, and obviously there's some confounding that we've already alluded to earlier in the conference. But you just want to be aware that that was really the purpose of that study, was marijuana and tobacco. Now, the one that Dr. Riggs referenced earlier is the MHPCD study. This is the one out of Pittsburgh, Pennsylvania. That started in 1982, and they've really looked at a high-risk population with low socioeconomic status, and they, instead of looking at marijuana and tobacco, looked at marijuana and alcohol as their 2 kind of areas of focus. And then most recently, there's this Generation R study that was started in 2001, and this is coming out of the Netherlands, which would probably be a great place to study things like this, right? And it's a multi-ethnic, higher socioeconomic status group. And I just am going to now walk you through, because they're longitudinal studies, what we see from the fetus, meaning still inside the belly, all the way through now up to 16 or 20 years for some of these studies that have now been published. And so we're seeing some interesting data from these 3 different studies. You can see here with regards to fetal development and birth outcomes that there's a huge discrepancy in terms of birth weight. No difference, increased and reduced. And then in terms of length, birth length, it appears that most studies seem to show a reduced birth length, but it's not statistically significant. And we also have other studies that also demonstrate conflicting results. So what I'm going to tell you in just a little bit is that I don't think there's much effect actually on the fetal birth weight or the growth at that time, okay? In terms of neonatal development, so again, the young infant, a couple months in, we also see some conflicting data. We see increased startles and tremors and reduced habituation to light, and these are the statistically significant findings from these studies in the OP study. And then in the MHPCD study, we actually saw no differences in behavior, but subtle differences in sleep recordings. And it hasn't been yet evaluated in the Generation R. For infant behavior, that was not evaluated in Generation R. For infant behavior, things start to get even a little bit more confusing. And this, I think, really drives home the point of Dr. Riggs' slide with all the arrows and things coming in, is that there's a lot of things that affect this environment. And so depending upon the age, you can see that there are often at least no or lower scores in BSID, which is the Bayley Scales of Infant Development. And the other thing that I think if you read through this is lower memory or memory functioning that we see in heavy cannabis users. And that's going to be one of the points that I'll drive home for you today, is that I think most of the effects that we're seeing in these longitudinal studies are from heavy cannabis users, which means 1 or more joints per day. That's how they define it. Again, I'm going to talk about the potency in just a minute, but that's how they're defining it in these studies. Again, relevant or not, it's what we have. And then you can see also the Generation R study, a little bit more aggression and inattention for the girls, but then that seems to kind of wane later in the study at up to 3 years. If we look now at the child behavior and cognitive development, I'm giving you a lot of the data of what we see at different time points that these studies selected. 6 years, 10 years, 12 years, 14 and 16. And any one of these studies could be the entire length of this talk. So I'm really condensing it down to a format which I hope will give you the kind of the general picture. And what I'm going to tell you in this slide, as we reach adolescence, there does appear to be a consistent, significant impact as a result of that prenatal exposure. Did you hear that? Okay, a significant impact on adolescent behavior and cognitive development consistently now in these studies when prenatally exposed to cannabis. And in many of these studies, they tried to adjust for the confounders that Dr. Riggs spoke of. So those have been adjusted for. Now, sometimes that does slightly change the results of the studies, but again, you're seeing here in parentheses several times heavy cannabis exposure. And so that's really where we're seeing a lot of that consistency is the heavy cannabis, and then as we get into that adolescent year. In terms of limitations, a lot of people who are cannabis users are also using other substances. They've tried to address this in the studies, but we know that, as you've already seen, there can be concurrent use. There are other confounding factors which may not have been accounted for in these studies. In terms of measures of illicit use, I've already talked to you about self-report. And that's how these women in all of these studies were asked about their cannabis use. So there was no toxicology reports to verify. The assessment measures, they were all validated, but I think if you put a group of behavioral health or child psychologists in a room, they would argue about which one would be the best. And we have 1 or 2 that were used for all of these studies. And that could be argued whether that was the best one or not. And then, of course, we've got studies going for 16 up to 20 years of time. We're going to lose subjects, one starting with 500 or 600. Now, over time, we may only get 100, 150 of that group. And that's just the nature of the study. It's the best we have. The other thing that I want to just talk to you about, and this has been alluded to in other presentations, is all these studies looked at smoked marijuana. We have a whole lot of other formulations that we are currently using. And so the effects of smoking cannabis may be very different from the other ways that we're ingesting it. And I think there's a lot of pharmacologic reason to think that may be the case. And then lastly, I want to emphasize the potency. Now, this is just in seized marijuana. And you can see here that the initiation of the study, the start of the study and tracking it happened back in the early 80s, and now going up to 2012, that's only going up to 12% potency. We know in any dispensary within 1 mile radius of here, you could get much higher than that. And if there is a dose-related effect, which I think there could be, we could be looking at different data based on what we've seen so far. So a summary, there's no effect for several of these outcomes, that there are effects for neurobehavior in the short term, and then the long term behavior, cognition, and achievement. Just a quick note on breastfeeding. We think that we know that it goes into the breast milk. A safe relative to infant dose for most drugs is considered to be less than 10%. You can see there that it's 0.8. And in animal studies, we do see that lactation could be inhibited. There are only 2 studies that I can find that are even worth mentioning in humans, and they really are not very well done, and they're old and they're inconsistent. We know that you could test an infant if needed to. You'll see positive urine tests for 2 to 3 weeks after the exposure. Overall, all the books, all the experts, everyone will say it's contraindicated in breastfeeding. So what are my recommendations? I think we need to really ask about use in this vulnerable population and maybe consider screening in high-risk patients. I think we need to educate them about these risks that we're finding in these longitudinal studies, and while it may not mean something now or even at the birth of your baby, it could potentially mean something later from that brain development perspective. We've talked a lot about offering services and counseling, cognitive behavioral therapy. Performing appropriate developmental milestones, I think, would be very important for this particular population and making sure that we keep on track. Counsel them about patient safety issues, and I know Dr. Wong's going to tell us a whole lot about the packages and what goes into that. And then avoiding still, just like we would for tobacco, secondhand exposure. And this is the labeling that's been approved. This was a result of the work of Dr. Riggs and myself putting this recommendation forward. To just let them know that there may be additional health risks, not only if you are pregnant or breastfeeding, but if you're planning to be, because we know that first trimester exposure may be at risk. And with that, I'd like to say thank you, and I appreciate your time today.
Thank you, Dr. Borgelt. Any questions from our other panelists? No? I have a question. Recently, the information provided in the late 80s and mid 90s around crack babies has caught fire and has pretty much been disproven, primarily due to the socioeconomic realities that you brought up here. Do you see the socioeconomic concerns pertinent in the research in this regard as well when it comes to marijuana and prenatal exposure?
Yes, I think the socioeconomic concerns will always be a concern because they influence so much of what a child decides to do in life. I do think what's going to keep this very interesting is the way that we use marijuana now is very different than how the marijuana was used in these studies. And not only just how it's being used, but also the strength of the marijuana. And so I think this is an area that we really should be concerned about and will want to be looking at, even if it is done like this, where we're asking women who are coming to dispensaries of reproductive age, do they know about this, or have they considered that, or what do they know? I'm curious about what they actually know. My medical residents told their patient who was breastfeeding it was completely fine. Now, it may not be completely horrible, but I'm certain it's probably not completely fine. And so I think there's a lot of perceptions out there as well that aren't maybe fully backed up with evidence.
Laura, do you know, if someone has a newborn and wants to quit marijuana, do you know, has anyone been counseling patients maybe to pump and dump or pump and dispose of breast milk till they completely come off marijuana, or get their breast milk tested to see how much THC is still left in the breast milk before they can start breastfeeding again?
So the recommendation coming forward from the American Academy of Pediatrics is to actually, if the woman cannot quit using cannabis, to not breastfeed. That's a very strong recommendation coming from that group because they are really strongly promoting breastfeeding for infants. And for those of you who are familiar with them, you can appreciate that recommendation. Having said that, other experts will really focus on harm reduction strategies. Screening may be a part of that. The pump and dumping, marijuana stays in your body for so long. It's a lipophilic substance, and babies are full of fat. If you've ever looked at one or held one, they're just marshmallows. And so they're a storage chamber for marijuana, quite honestly. And so because of the properties of the drug, which make it great in terms of going to the brain and other places of our body, it's just a different aspect when you're thinking about the child or the breast milk. Talk into it.
Okay. You mentioned that other forms besides smoking might be different. Do you have any thoughts on how?
So I think for things like topical exposure, much like other topical medications that we take, you really have very little systemic exposure. You really have very little drug getting into the system. I do think that with pregnancy, in terms of edibles, because your volume of distribution, meaning all the different places that the drug can go, and because it's so erratic with eating marijuana, that you may actually find a more significant difference in pregnancy when eating. So while topically I'm not really as concerned, I actually in some ways have more concern with the edible consumption. And vaporizing, I think, for all practical purposes probably lies somewhere in the middle.
Thank you so much.